take a man's soul and crush it out like a
Hello.
Hi, Padmaj. Good evening.
Yeah. Hi, Senthil. How are you?
Good.
Yeah. People are joining. We'll start maybe in 2 minutes.
Yeah. Whenever you say, I'm all set.
Yeah. It's 8 o'clock. That's what we usually start. 1 past 8. It's 1 minute to 8 now.
Okay.
We are on YouTube. So how are things?
As ignorant as ever, I suppose. Lesser you look for, the lesser you find. That's the best thing. Assume that everything around you is normal and continue.
I know. Everybody, I think the whole India is pretending that everything is normal. So which is good.
That's correct. At least you guys are showing some numbers. We refuse to do so. We are constantly at 2,500, whichever day you want to see that.
Yeah, I think that's the apparent, actual and apparent, the difference between actual and apparent. The more you test, the more your figures are, and if you don't test, everything is fine.
Absolutely.
Yeah. So I think you can share your screen.
I can share my screen. Okay.
Yeah, I've made you co-host, so you can share your screen. We would have your talk first. I'll introduce
Padmaj,
you.
just a moment. I need some help. I'm going to call my son to help me share my screen. This is a new system. He should do it in 10 seconds. Just hang on.
Okay. Yeah.
Should I use my old system? You can do this later. No. It's okay. Do it. Share. You could have shared, Raja. Click on share screen. Right.
Yeah, just share the screen.
What is this? Share now. Yeah.
Yes, I can see it
Perfect.
very well. You can, yeah, that's right. You can keep your camera on.
Yes. Just yes, I am.
Yes, that's it. So I think let's get going. I'll introduce you.
Okay.
And just topic in a couple of sentences. Then you start your talk.
Okay.
Everybody is on mute mode till you finish your talk. They'll keep on putting their questions in the chat box. And once you finish your talk, then we can answer their questions.
Done, Padmaj.
Yeah. So good evening, friends. Today is the next episode of IJM Pure Talks. Every Tuesday, 8 p.m., we invite an expert in his field and request him to talk on a certain topic, and then he will answer your questions. I am sure all the DM and DNB students who attend this are the advantage of the expert opinions of the stalwarts in the field in India as well as abroad. So today we have Dr. Senthil Rajappa, who is a senior consultant and head medical oncology in Indo-American Cancer Center in Hyderabad. And he is going to talk about the perioperative therapy of sarcoma. So it could be neoadjuvant or adjuvant therapy of soft tissue sarcoma. With this introduction, I request Senthil to start his talk. Everybody, please be on mute mode. Please put your questions in the chat box, and Dr. Senthil will answer the questions at the end. Very much for patient hearing. Over to you, Senthil.
Good evening, everybody, and thanks so much, Padmaj, for that very kind introduction. I am neither an expert nor a stalwart. I am as good or as bad as any one of you who's listening. It's just that I've done a little bit of reading and prepared for this talk. So the topic for today's discussion will be perioperative therapy of soft tissue sarcomas. And I hope at the end of this, you will not be left hanging as you're seeing in this particular picture. All right, so we all keep saying that sarcoma is a very rare disease, but I have to tell you that it's not as rare as what all of us think. Now, rarity is defined by the incidence per 100,000. For us, the sheer volumes in terms of numbers makes it not that much of a rare disease. We keep seeing it on and off. And every time we see it, we go through the many dilemmas that I will go through as we do this talk. What is this talk going to address? This is going to be on perioperative chemotherapies. Now, these are the questions that we will address. Who should get perioperative chemotherapy? What drugs? Should it be adjuvant or should it be neoadjuvant? What are the optimal doses of chemotherapeutic drugs? How many cycles should somebody receive? If you're doing both radiotherapy and chemotherapy, how do you sequence them? And what's the role of any perioperative therapy with metastatectomy? Now, all of us would agree that sarcoma is not one disease. It's at least consisting of 155 histotypes in the latest classification of sarcomas, and that's continuing to increase as we find newer entities with different biologies. Now, the most common seem to be GIST and liposarcoma, and then you get leiomyosarcoma and the many other small entities that you're seeing in this. Now, why is this important? Each one of these sarcomas, depending on where they arise, may have a different biology, which means a retroperitoneal leiomyosarcoma might have a slightly different biology compared to a uterine leiomyosarcoma, and so on and so forth. And the problem is that clinical trials have lumped all of these. So as they very jocularly say, you don't get that critical mass to really describe which entity benefits from what intervention and so on and so forth. So we are getting better in terms of our understanding, but has that really improved our understanding of the therapy? I think that's something that we will wait to see. Now we start with the diagnosis. So anybody who's got a lump that might be a superficial or a deep lump, which is more than 5 centimeters, should be suspected to be a soft tissue sarcoma. An MRI is the most ideal single tool for assessing the local extent of the disease. All of us would end up doing a PET CT scan in order to make sure that we are not missing metastasis, especially when you are going in for aggressive locoregional therapy. Extremely important is to get a good core needle biopsy. If you've got a very small lump, better excise it, because a core needle might sometimes not give you all the information. And in some specific situations, especially those necrotic masses, wherein core needle biopsy can miss the live area and open biopsy may be required. So this is very important to keep in mind. Why? Because diagnosis, getting your histology correct, is probably one of the most important steps in getting your patient to that endpoint called as cure. Now, this is from a European database which looked at 300 plus cases, and there were major discordances. When I say major, it's the subtype of sarcoma itself. The minor discordances are in terms of grade and margins and so on and so forth. Major discordances were found in 14% of all patients. Now, that I think is a big number, and you can't afford to go wrong in that many number of cases. So, getting your diagnosis correct, getting your immunohistochemistry as required, getting your molecular subtyping, those fusions, and all these things that are important in sarcomas today is extremely important step to get into the most appropriate therapy and achieving cure. Now, this is the staging of soft tissue sarcomas. Now, as always, staging is a little complicated, but let's make it simple. For the sake of the discussion today, all that you need to remember is T2, T3, T4, right? Which is more than 5, less than 10, more than 10, less than 15, and more than 15. So 5 to 10, 10 to 15, and more than 15. That's T2, T3, and T4. The stages that we are interested in today are stage 2 and stage 3, right? Now, stage 2 I have put up there also because sometimes these high-grade tumors may warrant additional therapy, but strictly speaking, it should be stage 3A, B, and C, because that's where you're looking at T2, T3, and T4, which is tumors that are more than 5 centimeter. So for today's discussion, all that you need to remember is that your tumor should be more than 5 centimeter. Now, generally, for sarcomas, having a node positivity means metastatic disease. Now, this A superscript is for retroperitoneal sarcoma, wherein having a lymph node does not make it stage 4 disease. It will still remain stage 3 disease. So remember, a higher grade, a tumor that's more than 5 centimeter, and for retroperitoneal sarcomas, lymph nodes being positive are the groups that we are interested in discussing today. Now, since we are discussing perioperative therapy, we will discuss only about localized disease today. Surgery remains the most important, and getting an R0 negative margin is an extremely important part of treatment for localized soft tissue sarcomas. How much margin should you get? I think that will depend upon many factors that are listed here. I will not go into those details. Who qualifies for radiotherapy? I have put up that list here. So a high grade, remember that sometimes grade 2 is also designated as high grade. So a high grade, a deep-seated lesion that's more than 5 centimeter warrants radiotherapy. Sometimes you might have a higher grade lesion that is deep and may also be less than 5 centimeter. Now that's where the biology and the subtype will dictate whether such patients get radiotherapy or not. Now, what is the benefit of radiotherapy itself? In majority of patients, it improves the locoregional control. There are some trials in patients with extremity sarcoma, wherein we know that radiotherapy also has a small improvement in terms of overall survival. So since it's a local therapy, what you need to importantly look at is locoregional failures, and it seems to be improving those locoregional failure rates, which means bringing it down in majority of the situations. Now, chemotherapy is the crux of the issue, and that's what we will go on to next. Right. Now, for a moment, let's assume that a patient has had surgery and is coming to you with the pathology report. What are the things that you want to look at in the pathology report? Of course, histology. When we say histology, it's not just whether it's a sarcoma or not. As we said earlier, you also need to clearly know what sarcoma is this. Is it the liposarcoma? Is it a leiomyosarcoma? Or is it an undifferentiated pleomorphic sarcoma? Or one of those very complicated names that this can get to? Grading, as we said, is an extremely important part of a pathology report. The factors that are considered to designate a grade are differentiation, necrosis, and mitotic rate. All these three factors are put together in order to designate the grade for a soft tissue sarcoma. As we said earlier, the margins are extremely important. Please remember that if there is a positive margin, your chemotherapy cannot overcome the negative impact of that positive margin. Please get it back to the tumor board or to the surgeon to discuss as to whether a re-excision will be possible. In some situations, yes. In some situations, no. But I think it's always important to make sure that re-excision is discussed whenever you see a positive margin. Now, for some reason, if you had a neoadjuvant chemotherapy being administered, you also want to look at how much is the necrosis. Not that this necrosis is going to help you change your therapy post-surgery. It's because patients who respond well to chemotherapy are likely to do well in the long run. Now, one thing that I have not mentioned here is size, because size comes in the next slide as an important part of risk classification. So what are these important things that determine the risk? When I say risk, what is the risk of recurrence? What is the likelihood that somebody will die because of this particular tumor that you have diagnosed? Now, one, tumor grade, we spoke about it. As the size keeps increasing, the likelihood of relapse keeps increasing. The deeper your tumor in response to the fascia, the higher is the chance of a recurrence. Status of surgical margins, as we said earlier, is an extremely important prognostic factor, especially for local recurrence. Now, tumor rupture is an important prognostic factor for retroperitoneal and abdominal sarcomas, especially in the context of GIST, because rupture puts you at a higher risk of recurrence. And for patients with GIST, that's an important criteria that we use in order to determine their eligibility for adjuvant therapy. So the grade, the size, the tumor site, and the margins are extremely important in determining prognosis. Now, there are some online calculators and nomograms that are available. This one is referred to as the Sarculator, which tells you what is the likelihood of the 5-year overall survival, distant metastasis, and so on and so forth, depending upon where the site is, the age, the tumor size, the grade, the histology, and so on and so forth. But please remember that this is a prognostic calculator. Now, a prognostic factor is something that tells you that if this factor is present, your patient is likely to benefit from a particular therapy. Now, I'm sorry, did I say prognostic? A predictive factor tells you whether you will benefit from therapy. A prognostic factor tells you how good or bad you're likely to do in the future. But remember that all prognostic factors need not be predictive factors. For example, you might have a patient with a huge tumor, which is prognostically bad, but that does not tell us that this patient should have chemotherapy and will benefit from chemotherapy all the time. So prognostic factor is different and a predictive factor is different. We should not assume that bad prognosis always translates into a good predictive factor. And this is important to remember across anatomic sites, not only in sarcoma. Remember that bad prognosis need not necessarily benefit from the type of therapy that you're offering. So now we come to the crux of the issue. Should it be adjuvant for resectable tumor or should it be neoadjuvant? We won't go into the question of what do you do with an unresectable tumor today. So let's start with this patient case. Here is a 35-year-old man who's got hepatitis B, but the liver function is normal. His hepatitis B is not active anymore. He presents with abdominal pain. Clinical exam is unremarkable. He's got a huge retroperitoneal mass, 25 centimeters, with suspicious involvement of all the structures around. A PET CT was done, no evidence of systemic metastasis. A biopsy was done that showed a high-grade leiomyosarcoma. Now, what are the options for this patient? Surgery only? Surgery followed by adjuvant chemo and radiotherapy? Surgery followed by adjuvant radiotherapy alone? Or should it be preoperative chemotherapy, radiotherapy followed by surgery? Now, I think your approach to a patient like this is an extremely important step to getting your treatments right. So the question that I will ask myself when I'm confronted with a situation like this is, one, can you get an R0 resection in this patient with acceptable morbidity? Two, is even if it is resectable, would some neoadjuvant treatments add value at all? Because as a medical oncologist, these are the two important questions that one should ask oneself, apart from what's the grade and what's the size and whether it's metastatic or not, or is this chemo responsive histology and so on and so forth. I think for practicality, these in my mind are the two most important questions. But not everybody has the luxury like me of having good surgeons who will discuss, who will take a point and then decide what to do. This patient was operated by a person who probably, I'm not pointing to anybody in particular, thinks that everything and anything first should come out and then that should be followed by any systemic therapy afterwards. So look at what happens. This patient has a resection of the tumor along with the left kidney, the tail of pancreas, the spleen, and a segment of the ascending colon, right? Look at the number of things that have come out along with this tumor. That's really morbid for a 35-year-old who's got hepatitis B, though that's inactive. So this is proven to be a leiomyosarcoma. Fortunately, the margins are negative. The cells are within 1 to 2 millimeter, but then you can always argue, is a 1 to 2 millimeter margin good enough for a 25 centimeter high-grade retroperitoneal leiomyosarcoma? Now, that's not for today's discussion, but that's something that we would always ask when confronted with a high-grade tumor. Now, should we do chemotherapy now or should we not? I think the whole world is divided. I wanted to put my picture here somewhere because I really don't know the appropriate answer. And if you think that at the end of this talk, you're going to have a categorical answer to carry tomorrow morning to practice, no, you're going to be disappointed then. I'm just going to share what I think should be done in a situation like this. So let's get into all those trials very quickly. I won't bore you with all of these. Now, this is the first meta-analysis, 1,500 patients. We clearly will discard this because by today's standards, the numbers of patients, the endpoints, the kind of drugs that we use, the population of patients studied were all not optimal and acceptable. But in spite of that, your risk of recurrence came down by about 10% at 10 years. That's not a bad number, should I say. If you had seen the same number in breast cancer, you would jump with joy and say that I want to adopt this extremely expensive therapy for bringing down the risk of recurrence by 2.5%. But this is something that we will not accept because the reasons are very, very different. Let's not go into that today. Is there an overall survival benefit? The answer is no. You see that the diamond is clearly crossing the line of unity. So that overall survival is not significant, but the overall relapse rate is not bad at all. Now, there are some signals that you get from the subset analysis. That is, when you look at extremities, there seems to be an overall survival benefit at the end of 10 years. Now, again, that's only a trend to overall survival benefit. You see that the confidence interval again crosses the line of unity. So what does this tell us? There is some signal saying that extremity sarcomas might actually benefit from chemotherapy. The next one that came quite long after that. Now, this is a very famously quoted EORTC study of 351 patients. We used ifosfamide and adriamycin, the drugs that are most important for soft tissue sarcomas. And look at those Kaplan-Meier curves. You don't have to go close and look at them. The lines are sitting one on top of the other. So how will the authors conclude? That there is a trend for better relapse-free survival and overall survival. And whenever we fail in a trial, we are so good at going back and explaining why this trial was not successful. So it was based on the grade, the size of the tumor, the site. So we find so many reasons to say why we failed. And sometimes it's difficult to accept failures after you design such a good study. But there are always learnings from every study. This clearly shows again that tumor size is prognostic. Clearly, we are not seeing any benefit because the confidence interval again crosses the line of unity. It tells you that 10 centimeter is prognostic. There seems to be some benefit. Grade 3 seems to be some benefit. And again, with radiotherapy, when you combine, there seems to be benefit. But again, at the end of the day, the diamond is crossing the line, so no improvement in outcome. We then move on to the second generation studies of anthracyclines plus ifosfamide. Again, the standard. Look at the kind of mess that we have made with all these studies. Look at the patient numbers, 100, 88, 59. Now, nobody would accept a study like that. The largest is 350. Look at the doses of the drugs that we have used, anywhere ranging from 60 milligrams of epirubicin to 75 milligrams per meter square of doxorubicin. Look at the number of cycles and the intervals. Some have used 3 weekly, some have used 4 weekly, some have used 3 cycles, 5 cycles, 6 cycles, 4 cycles. So we have done every damn thing under the sun. So for me, what does this mean? It just means that we are not really clear about what we want to do and what we want to get out of this, right? That's the simple inference that I'm coming to when you got a mess of these studies sitting in front of you. But again, some very important learnings. If you have a study where the grade is uniformly high, if you have a study where it's extremity sarcoma, then there seems to be some benefit in terms of overall survival, right? So this is something that we learned from our earlier meta-analysis. Okay. Now here, there is a trend. Again, the longer follow-up did not continue to show the overall survival benefit here. So there may be some patients, high grade, extremity sarcoma, chemo-responsive sarcomas, who may benefit in terms of overall survival from chemotherapy. But when you look at a dose-dense fashion, increasing the number of drugs and doing 6 cycles in 59 paltry number of patients, the result is obviously negative. So I think it's a bag of confusing studies. What we need to learn is that some patients might benefit. And who are these patients? These are patients who have high-grade extremity sarcomas. There seems to be some clearing in terms of the literature there. So whenever there is confusion, what do? We do a meta-analysis immediately. So remember that in a meta-analysis, the quality of the meta-analysis always depends upon the data that goes in. As they always say, garbage in, garbage out. So what does this meta-analysis say? There is a 6%, 10%, 4% absolute benefit for local disease-free survival, distant metastasis-free survival, but the overall survival is not statistically significant. Again, getting nowhere. You go in and dissect now. These are the newer data from the meta-analysis. Now, this was updated at the ESMO 2017. So, for patients who received doxorubicin and ifosfamide, very interestingly, there is not much benefit in local recurrence because the confidence interval is beyond 1. There is a benefit in terms of distant recurrence. There is a 40% risk reduction. Overall recurrence, again, a 40% risk reduction. And very importantly, a hazard ratio of 0.56, which is a 44% improvement in the relative risk of dying when you take doxorubicin plus ifosfamide compared to if you don't. There, the upper limit of confidence interval is less than 1. So finally, you did meta-analysis upon meta-analysis. You dissected through the drugs, the histologies, the grades, and the combinations. And finally, for somebody who wants to get some evidence to go ahead and treat, here is the evidence if you want to do that. Now, what's the absolute benefit? That's about 6%. Number needed to treat is 17, which means for one life to be saved, you need to use chemotherapy on 17 patients. Remember this. So 16 are unlikely to benefit from this intervention. Now, again, the analogy is breast cancer. You would have jumped with joy. 6% is what you get as overall survival when you use trastuzumab for patients with HER2 positive early breast cancer. So not at all bad in terms of the benefit that you're getting, but I think this is from a meta-analysis. That's reasonably good level of evidence. Why am I saying reasonably and not level 1? Because this is, again, subsets that you're getting from this meta-analysis to really see if one group of patients benefit beyond the other. But remember that all these meta-analyses have not convinced either the ESMO or the NCCN to give you a blanket recommendation saying chemotherapy should be done as adjuvant. Now, let me read this through. ESMO says chemotherapy is not standard treatment in adult type STS. It can be proposed as an option to the high-risk individual patient. Now, who is that high risk? We said that earlier, higher grade, deep-seated, more than 5 centimeter tumor. What does the NCCN say? Post-operative chemotherapy for stage 2 and 3 patients is recorded as a category 2B recommendation. Now, that's not high level of evidence. Remember, NCCN will jump to really, take everything that comes in way of literature to recommend that. But I should say that they have been very tempered in saying that it's a category grade 2B recommendation. So, having decided that there may be some benefit for adjuvant chemotherapy in subsets, should you do this chemotherapy adjuvant or should you do it neoadjuvant? I think that's a bigger question. So how do I think we should be approaching this problem or point? I think this algorithm gives you some signal towards it. It says that if you have a grade 2 or 3 tumor, surgery straight still remains an option, and then chemotherapy is an option low down there. Now, it also says that if you have those high risk criteria, you might use chemotherapy plus minus radiotherapy. That's a 2C recommendation, and then follow it up with surgery. So which is the optimal approach? Should it be something like neoadjuvant or should it be adjuvant? So the way I look at it, the questions that I will have to ask myself is, first, does this patient warrant adjuvant chemotherapy at all? Okay, so the question I'm asking before surgery is, if this patient has surgery and comes back to me, am I going to do adjuvant chemotherapy or not? Now, if the answer to that question is yes, now the reason might be varied, starting from a high-risk tumor in a young patient to a highly chemo-responsive tumor in an older patient, and so on and so forth. So if the answer to question number 1 is yes, then you probably should consider doing it neoadjuvant. Now, contrary to many other sites, what are the potential advantages of doing this as neoadjuvant? Now, immediately, let's not jump like breast cancer and say, I want to achieve a pathological complete response. Remember that in sarcoma, the possibility that you will achieve anything like that would be less than 5%. So that should not be the intention of therapy. What should be the intention of therapy to put it neoadjuvant? One is your patient in doubt of getting that R0 margin? Is your patient likely to have a morbid resection? Now, that could be sacrificing your limb. It could be sacrificing multiple organs in your abdomen. So in a situation like that, if you have a high-grade tumor that's chemo-responsive, should you be doing it neoadjuvant? The answer probably is yes. The question is, it's resectable with acceptable morbidity. Should you still do neoadjuvant or not? The problem becomes a little more critical there. I think the answer probably is I would be less tempted to do that. Now, where is one situation I would be tempted to do that? If somebody has a high-grade large tumor but resectable in the abdomen, retroperitoneum, and if I have the doubt that this patient is less likely to make it to adjuvant chemotherapy. Why? Because some patients don't recover well after abdominal surgeries to be able to get that chemotherapy done, right? So that's probably a situation where I would be tempted to do neoadjuvant, even if the tumor is resectable with acceptable morbidity, right? I hope I made my point clear. So let's go through that again. Neoadjuvant or adjuvant, decide the need for adjuvant chemotherapy first. If you're convinced that this patient is going to benefit from adjuvant chemotherapy, then consider doing it neoadjuvant. If it's resectable, is there a huge advantage of doing it neoadjuvant apart from showing prognostic value? The answer is very small. Where would I do it? In an abdominal tumor that's large, wherein I've decided that this patient will benefit from adjuvant, but because of the magnitude of surgery, he or she is unlikely to come back to me, and hence I want to do this as neoadjuvant because I don't want to deny this patient a life-saving therapy, right? So that's my way of looking at it. We can discuss that. This is debatable too. What does the NCCN say? Though I appreciated the NCCN exactly 5 minutes ago, I would want to take that back sometimes. The reason is a recommendation like this does not really help. It tells that you can do whatever you want. This is an extremity tumor. You can do surgery. You can do preoperative RT. You can do preoperative chemotherapy. You can do preoperative chemotherapy plus RT. That rarely helps somebody who wants to take the guideline to help them make a decision. Retroperitoneal sarcoma, again, same. Preoperative therapy with radiotherapy or chemotherapy and then surgery, or surgery straight away followed by adjuvant. It gives you both. So I think all of us should work some kind of an algorithm in our mind and say, okay, this is the kind of patient that I want to do neoadjuvant. This is the kind of patient that I would do adjuvant. And this is the patient where I don't want to get anywhere close to because I don't think this patient will benefit. Now, this is the only slide I have about radiotherapy because we keep talking about preoperative radiotherapy. Now, in patients with extremity sarcoma, there seems to be an advantage of preoperative radiotherapy. How is that? In some studies, the R0 resection is better. When you do preoperative radiotherapy, the doses you use are less. The tumor gets walled off beautifully by a fibrosis and can help surgeons. The long-term morbidity of radiotherapy is less. But in some studies, the complications post-surgery with respect to wound healing can be a bit of a problem. So there seems to be an advantage of preoperative radiotherapy in patients with extremity sarcomas. What is the story with retroperitoneal sarcomas? Because whenever you send a patient with a retroperitoneal sarcoma after surgery for radiation, the question that the radiation oncologists will ask is, what do you want me to radiate? There is nothing like a tumor bed now. You got all the viscera sitting on top of that bed, and all you're going to do is burn up your intestines or the organs that are coming in the field. So they're always wild when we send patients after surgery. So is there a trial looking at preoperative radiotherapy? Yes, this is called as the STRASS study. But unfortunately, the STRASS study showed that the abdominal relapse-free survival was no different whether you did preoperative radiotherapy followed by surgery or surgery straight away. Now remember, these are for patients with operable retroperitoneal sarcomas. As always, there were a small set of patients listed at the bottom who benefited, but it looks like with a median follow-up of 43 months, the strategy of preoperative radiotherapy cannot be applied to everybody. We've got another 5 minutes. We'll quickly run through what about number of cycles and the interval. 3 to 5 cycles at 3-week intervals is what we should be doing. How do we know that? It's based on this study that randomized patients to 3 cycles of neoadjuvant chemoradiotherapy followed by surgery, or chemoradiotherapy 3 cycles pre-op plus 2 cycles post-op. This was a high grade, good doses of epirubicin and ifosfamide that was used. There was no difference in the 5-year overall survival. So it looks from this study that 3 cycles are good enough, because for us as medical oncologists, whether you give it as pre-op or post-op, as long as all the therapy is delivered, the benefit is likely to be achieved. So if you've got 3 neoadjuvant in the other arm and 2 as adjuvant, and the relapse-free survival, overall survival was no different, it tells me that 3 is equal to 5. But unfortunately, if these 2 additional arms had been there, it would have answered more questions, but that was not to be. So that's the evidence that we have. The next question is histology specific chemotherapy? The moment you say, I want histology, many people ask, what are you going to do with that histology? One of the things we tell them is, I want to choose my chemotherapy based on the histology. So is histology-based chemotherapy useful? The second question that I'm asking myself is, the trial that I'm going to show you, does it support adjuvant chemotherapy itself? Because that's something that we need to think of. So what did they do? These were extremity sarcomas, again, the high-risk group, epirubicin or adriamycin, ifosfamide, 3 cycles followed by surgery. Those were the list of histologies and the chemotherapies that were based on the histology. It clearly showed that doing histology-specific chemotherapy was inferior in terms of disease-free survival and overall survival. So no histology-specific chemotherapy. In fact, the trial was terminated early. But the question that I'm asking myself is, we spoke about high-grade, high-risk extremity tumors, and here you've got ifosfamide adriamycin showing better overall survival compared to another chemotherapy. Unfortunately, you didn't have an arm without chemotherapy at all. So if for a moment we assume, I'm saying assume, that the histology-based chemotherapy was at least as good as no chemotherapy, let's hope that it was not detrimental to not doing any chemotherapy at all, then can you consider this as some evidence for adjuvant chemotherapy, at least in extremity sarcoma? I really don't know the answer, but I'm tempted to say that this trial, for me, though, is saying that histology-specific chemotherapy is not useful, is to a certain extent saying that adjuvant chemotherapy might improve overall survival. And across histologies, there was no benefit there. So to summarize, adjuvant chemotherapy is not standard treatment in adult type soft tissue sarcoma. Now, this is the ESMO guideline, but it can be proposed as an option to the high-risk individual patient. Okay, we are coming back to where we started with. I tried to put in a lot of my ideas and try to crystallize it, but I want to conclude with a simple guideline. Neoadjuvant chemotherapy with anthracyclines plus ifosfamide for at least 3 cycles is an option in the high-risk individual patient. This is neoadjuvant. And look at this, it's a 2C recommendation. There is moderate evidence for clinical efficacy, but a major clinical benefit. Now, for me, that recommendation sounds very ironical. You can't say there's moderate evidence of efficacy, but a major clinical benefit. Again, we can discuss that. I told you about my thoughts and ideas of neoadjuvant chemotherapy and the specific situations I may want to do. Who's at high risk, greater than 5 centimeter, a high grade? Which are those chemo sensitive sarcomas, pleomorphic, undifferentiated? L sarcomas is the lipo or the leiomyo, MPNST, synovial sarcoma. The last slide. What about the drugs? Without any doubt, if you decide to do, it has to be ifosfamide and doxorubicin. What about the doses? It has to be between 6 and 9 grams of ifosfamide per meter square and around 75 milligram per meter square of doxorubicin. You could use a higher dose of epirubicin, let's say 90 milligrams per meter square. How many cycles? Most studies have used either 5 or 6, but I would argue that 3 may actually be good enough. They may not be a good reason to hammer your patient with lots of chemotherapy and create more trouble. And the reason why I'm saying 3 might be enough is we showed evidence that 3 is as good as 5. What about sequencing radiotherapy and chemotherapy? Radiotherapy should come after chemotherapy. What about post-metastatectomy? I think, again, there's no recommendation for either the neoadjuvant or the adjuvant strategy. So I think you need to individualize again in that particular situation. So if there is one place in the anatomy that you're using evidence-based ignorance, I think sarcoma is that one place. But at the same time, if you're using evidence-based medicine in the absence or very little evidence, that's again sarcoma. Because remember that evidence-based medicine is not just research-based medicine. It's a combination of best evidence, clinical expertise, and ultimately discussing with your patient the benefits versus the risks of therapy. And this is what you should do in pursuit of the best possible outcomes. So I think I'll stop there and take questions if there are any. Thanks so much, Padmaj, for that opportunity. I am at least wiser after this talk because I have read reasonably well for this talk. Thanks so much. Padmaj, take over, please.
Yeah, thank you very much, Senthil. I think that was gist of sarcoma. Many times, the more we read, we know. The more we know that we know not as much. So, sarcoma is, I think, the area which requires, because it's a mixed basket, it requires a lot of research, and hopefully we get more and more drugs and we move forwards. But we go with what we have right now. There are questions. I think there are few questions. One is, what is the minimum information required in limited small samples pathology report for deciding intervention chemotherapy?
I think the subtype and the grade are the least things that I would want to be in a pathology report, even if it's a small biopsy.
Right. What are the indications for a preoperative in extremity or RP sarcoma?
So I think the important thing is that we just showed evidence that retroperitoneal sarcoma typically does not warrant preoperative radiotherapy, at least based on the STRA study, except in very selective subgroups. So if you ask me what the indications are in retroperitoneum, there seems to be some benefit with preoperative radiotherapy for the dedifferentiated liposarcoma. There seems to be no benefit for the leiomyosarcoma there. Low-grade tumors seem to be benefiting. So you've got a large low-grade tumor in the retroperitoneum. One of the things that you could consider is doing radiotherapy preoperatively, because that's one indication for radiotherapy there. I think in patients with extremity sarcoma, what is important is that in patients who have these high-grade, high-risk ones, that's more than 5 centimeter and so on and so forth, radiation seems to be indicated because there are some studies where you have an overall survival benefit also. So as we said, there are advantages of doing radiotherapy preoperatively because it condenses the tumor. The R0 resection is higher in patients who had pre-op. The doses are lesser. The long-term problems associated with radiotherapy are lesser. So if you're going to do radiotherapy, I think the trend now is to do it pre-op. So those are the indications for pre-op radiotherapy in extremity and retroperitoneal. Satyajit Pawar has asked, in what cases will you combine RT and CT as neoadjuvant approach? So Satyajit, I think we went through that in the course of the discussion. Question number one, does this patient warrant adjuvant therapy? If the answer to that question is yes, you can do that as neoadjuvant therapy, not necessarily as adjuvant, but not all patients and situations warrant that. Right. Pradeep Babu has appreciated. Thanks, Pradeep, for that very kind words. Can you please suggest how to deal with reports saying high-grade spindle sarcoma, IHC not contributory, particularly in the metastatic setting? Pradeep, if you take the metastatic setting for the first line, it's ifosfamide plus adriamycin or single agent adriamycin. Ifosfamide plus adriamycin is combined only when you are interested in the response rates, because the combination does not give you better overall survival compared to adriamycin alone. So for the first line, it may not really matter, Pradeep. But as we go in to the second line, wherein you may want to use some histology-based chemotherapy, I think that's a situation where you would certainly want this information. So I would go in for another biopsy, send it to a different pathologist, keep chasing that to get that histology, because second line onwards, I think there is a role to do histology-based chemotherapy in the metastatic setting. How do we define deep and superficial? It's based on the deep fascia, you know. Deeper to the deep fascia is a deep tumor and superficial is the superficial tumor. So that's how we define deep and superficial. Abhinil has asked your take on the use of neoadjuvant trabectedin, especially translocation related. No, Abhinil, I think we've got good evidence today to say that histology specific chemotherapy should not be used in the curative setting. So I wouldn't want to use trabectedin in the neoadjuvant setting, even in a translocation related sarcoma.
Yeah, I think one of the answer for Pradeep's question could be if IHC is not really helping, repeating biopsy, as you said, and maybe cytogenetics or molecular translocation studies might help in such cases.
Absolutely, absolutely correct. Absolutely.
Any other question? Anybody else? Yep. Venkat has asked another question.
Paratesticular sarcoma, lung metastasis, progressed on VAC, IE, and then on gemcitabine, docetaxel, progressed now, and patient is fit. So I would say, you know, try to sequence your tumor and then see if you will get some leads, because third line treatment, there's no standard protocol as such. You need to get to those salvage protocols and see if there are agents that you haven't used so far and then use one of them, Pradeep. So I really don't have a simple answer to that question. So I think we need to go back and look at those protocols and get more tests done to see if some therapy will help.
I think that probably gets us to the end of the session today. Thank you very much, Senthil. It was wonderful to have you with us. Friends, we finish off the talk today and we'll meet next Tuesday 8 p.m. with another expert and another talk. Till then, thank you very much and good night.
Thanks so much, Padma, and thank you so much. Thank you.